Hello everyone, good evening. Continuing with our table Viva series, today is part 3. We've had 2 parts yesterday of short duration. Today will be a longer class. So let us try to cover more than we did yesterday. Some more specimen instruments, operatives mainly, and some interesting x-rays at the end, just to make you think a little bit. If you guys can see me and hear me clearly, then please give a thumbs up in the chat. I can see you guys on the YouTube chat box. Okay. Alright. So please be interactive in the chat. I can see all your messages. As people are joining in online, just let me tell you how today's class is going to be. But before that, those of you coming for my class for the first time, I am Dr. Amrit Nasta. I am a bariatric surgeon from Mumbai and I am your surgery educator on Unacademy. Please follow me on my profile on the Unacademy learning app where you will get regular updates about my upcoming classes. Tomorrow we have another class, same time 6:30. That is an image based class, images only. So it's an image based class. It will cover images in surgery as well as in orthopedics, so double benefit. That will also be a class of about 1 hour 1 hour 15 minutes duration. There are a lot of other educators like me on the platform whom you can join, and remember, those appearing for NEET PG, please take the plus subscription where you can avail of a intensive revision batch course which has just begun a few days back. It will help you prepare for your NEET PG in April 2021, and you can use my referral code 10surgery and that will get you a discount. Tomorrow there is Unacademy combat quiz that is at 5 o'clock. Please register for it, go for it, try your luck. It's on second MBBS subjects, but I'm sure all of you going for NEET PG would be preparing these subjects. So you never know, if you come in the top 3 ranks, you'll get some amazing vouchers, and of course up to a lot of ranks you'll get some of the other prizes. Amazing prizes free of charge. Just register and go for it. You never know. You may get lucky if you have the medal. It may be your lucky day. Some amazing prizes to be won. Alright. Okay. So like we did yesterday, I will construct the class starting with specimen, just to give you an idea what kind of specimen are going to be there, what kind of questions will be asked on these specimen, how are you going to identify expected questions, and where the Viva is going to go. Okay, so let's see if you guys can identify this interesting looking specimen. So there are 3 parts of the specimen. Take a pick whichever you want, and we discussed how we will go about the specimen. First we will talk about the organ. So first thing first, what is the organ? What do you see? What are the parts? Then what is your diagnosis? And then the expected questions. So tell me, what do you think this organ is? And what is the specimen like? What is it made up of? Looks funny, but trust me, these are the kind of specimen they will keep. This is actually how it looks. You're saying intestine. Is it small bowel or is it colon? And what part of it are you saying? Is it small bowel or is it colon? Farhat is saying small bowel. Advait is saying jejunum. Okay, even better. Next question would have been jejunum or ileum. Why is it small bowel? And why not colon? Mm-hmm. Yeah. Why is it not colon? So first things first, how do you differentiate small bowel from colon on a specimen? What are the points? 1, 2, 3. And then I will tell you how do you identify jejunum versus ileum. Why are you labeling it as small bowel? Okay, so first things first, you should have said, I cannot tell for sure whether it's small bowel or colon because I want to look at the external surface. Till you don't see the external surface, you cannot comment what organ it is. Okay, because from inside they don't look very different. I'll show you. From inside they don't look very different. From outside you can clearly make out is it small bowel or colon. What do you see in the colon that you don't see in the small bowel from external surface? Absolute exam question. इसके बिना you cannot say this is small bowel or colon. Hostrations indicate large intestine. Do you see any hostration? So one thing that colon will show is called hostration. Small bowel doesn't have hostration. Okay, tinea, very good. Tinea coli. Mesocolon. Now mesocolon depends on the part of the colon there is. Small bowel has mesentery. Colon does not have a mesocolon except in some parts. Some parts of the colon will have mesocolon, like transverse colon, sigmoid colon will have a mesentery. Baki will not have. So you cannot say mesentery will tell me whether it's small or large bowel. Hostration, yes. Tinea coli, yes. What is the third thing? Very good. There are fatty appendages called appendices epiploicae. Appendices epiploicae. All of these three are missing in the small bowel. This is how you will differentiate the two. Okay, on the cut surface you can't really make out. On the cut surface, okay, there is one thing you can see on the cut surface in small bowel. You see these folds. These folds are called plicae semilunaris. They are present abundantly in small bowel. They are present a little less in colon. So ऐसा नहीं है कि colon will not show these folds, but they will be very crowded in small bowel. More the folds, more the absorption. Right? More the folds, more the absorption. Colon does not absorb much. It will only absorb a little bit of water, not much of electrolytes. Most of the absorption is in the small bowel. So you will have more of these plicae in the small bowel. So from inside, you can't comment. Whenever you are given the specimen, please look at both the surfaces. So when you will start describing, you will start describing it as this is a cut section, okay, of bowel. So this is a cut section of bowel. You are not commenting small or large bowel. Then you will start describing the external surface. So you will say on the outside, do I see the hostrations? Hostration means these kind of folds. These are hostrations, which you see in the colon, which you will not see in the small bowel. You will see tinea. I will show you how tinea looks. You will see tinea coli. You will see appendices epiploicae. I will show you all of these, don't worry. So you will say it's colon. If you don't see any of these, you will say no hostrations, no appendices epiploicae, no tinea coli. So this is small bowel. First part is proving it is small bowel. Then you look at the cut surface. Cut surface will show plicae semilunaris. Again goes in favor of small bowel. Then the examiner will ask you, is it jejunum or ileum? So anybody can tell me, how do I differentiate jejunum from ileum? Because they look very similar. Let me tell you, even surgeons can't differentiate many times jejunum from ileum. So what is the difference between jejunum and ileum? Yeah. So first you have told it is not colon because these things are not there. Plicae semilunaris in jejunum, they are there in both. ऐसा नहीं है कि सिर्फ jejunum में होंगे. They are there in colon also. Anything else? Anything else apart from plicae? So one thing is in jejunum the plicae are more crowded, but then you need a reference point, right? In ileum they are less crowded, but that is a reference point. वो थोड़ी तुमको मिलेगा. They are not going to give you jejunum and ileum side by side and tell me which is jejunum, which is ileum. They are not going to do that. इतने तो उनके पास specimen भी नहीं होंगे. So then what will you say? This is one way, fine, but that is comparative. Any other way of differentiating jejunum from ileum? Mesenteric blood vessels branching. Very good. In what? They are branching in what? I'll show you the picture. Now you can see. So from outside, the jejunum is relatively narrower lumen. These the blood vessels, they are called vasa recta. They are called vasa recta. They are long. In ileum, the vasa recta are branched. Okay. In a specimen, you will not see the vasa recta. Forget about it. These are going to be resected specimen. तुमको blood vessel नहीं दिखेंगे. And on the cut surface, I told you, you will see more plicae. You will see less plicae. But you will see more Peyer's patches. If you are lucky, you may see Peyer's patches. Peyer's patches are the lymphatic patches. They are seen more in the ileum. They are seen maximum in the terminal ileum. So these are ways of differentiating. Really speaking, looking at this, you can't say whether it's jejunum or ileum. Okay, whatever you say, even the surgeon will not know for sure whether it's jejunum or ileum. So whether you call it jejunum or ileum, it's okay as long as you can justify that these are the points which are seen in jejunum, these are the points which are seen in ileum. Because there are more plicae semilunaris you are seeing, you can say, okay, probably this is jejunum, no problem. This is your organ identification. Now you are going to identify the pathology. Let's look at the first one, the first image. So let's say this is a cut section of jejunum in a formalized jar. What do you see in this? Something similar you are seeing in second and in third. This is a very classical exam specimen. It's the kind of specimen you should identify from a mile away. It will be kept in a very big jar. You should not lift that jar because the jar will be very big. You should just move it around and see what it is showing. Very good. So in this you see a single transverse ulcer. What do you see in the second specimen? इसमें क्या दिख रहा है? What do you see in the second specimen? Transverse ulcers. Okay, so you see one ulcer over here. You see something over here which looks like an ulcer, but something has gone wrong. So there is a stricture. And over here you see maybe an ulcer here, an ulcer here, an ulcer here, and narrowing over here. So maybe multiple strictures. So these are three different slices of jejunum. In the first, you are only seeing a transverse ulcer. In the second, you are seeing a transverse ulcer plus stricture. In the third, you are seeing transverse ulcers plus multiple strictures. Examiner will ask you, what is your diagnosis? So you will describe, this is a cut open specimen of jejunum. Outer surface is showing this. Cut surface is showing transverse ulcer or transverse ulcers with narrowing. So probably these are jejunal or ileal ulcers which have strictured. Then examiner will ask you, what is your diagnosis? What will be your diagnosis? Yeah. What is your diagnosis? Very, very important. TB. TB of what? All shortcut answers. TB of what? Any other differential you would like to give over here? Can it be anything else? Can it be anything else apart from TB? Typhoid, very good. So you will say multiple ulcers with stricture. I would like to give differential. Could be tuberculosis. IPD. Which type of IBD could it be? Which type of IBD? You know there are two types of IBDs, actually three types. Which type of IBD? Ulcerative colitis, excellent. Ulcerative colitis. Which part of the intestine does ulcerative colitis involve? Which part of the bowel does ulcerative colitis involve? Advait and Mayuresh, I should ban you from attending my classes for giving such outrageous answers. Ulcerative colitis. First you commit this is jejunum. Then you commit this is ulcerative colitis. Proctocolitis. Yes, please remember ulcerative colitis starts in the rectum and ascends proximally, involves the rest of the colon. Rarely ever will it reach the terminal ileum. Rarely ever. Jejunum तो कभी नहीं जाएगा. उसके पहले patient मर जाएगा. Okay, it will never reach the jejunum. If you find one ulcerative colitis in the jejunum, then you can make a report of that. It will be a historic finding. Okay, so please don't call it ulcerative colitis. Ulcerative colitis is proctocolitis. Yes, you can call it Crohn's disease. You are giving differential diagnosis, so you can't be thinking of anything else. You can call it Crohn's disease. Any other? Any other? See, when you think like this, no, only then your mind will really open up. Where am I going wrong? Is my thought process wrong? How will I answer in the exam? This is what you need. When you start speaking your mind, then you will start filtering what should be said, what should not be said. Amoebic. Again, amoebic. Where does what part of intestine does amoebiasis affect? Typhlitis we have already counted. Typhoid is typhlitis. Typhlitis means cecum, just for your information. This is not cecum. So then again, this is jejunum. So again, you give these answers, be prepared for the cross question. Any other diagnosis you would want to give over here? Any other diagnosis? Atypical amoebic. Okay. Better not to say such things because you will be able to answer everything on intestinal TB and nothing on amoebiasis. So let's not bring amoebiasis. It's not in our domain. Because then the examiner will ask you most common site of intestinal amoebiasis, which you may or may not know. Then he will ask you what is amoeboma, what does it mimic, and treatment, and then everything will start falling apart. Jabki ileocecal TB is like in your domain, right? So don't let your Viva fall apart by giving atypical answers. Okay. Anything else? Any other differential for a specimen like this? Rare cause. Common causes we have enlisted. Crohn's ileitis or Crohn's disease, tuberculosis, typhoid, any other rare cause where you will get multiple ulcers or strictures. Rare cause. But can be put in your differentials, and then you will be happy to take your Viva on those things because it is something within your domain. Anybody? There are so many of you online. Anybody? Maybe mesenteric ischemia causing focal gangrene. Does this look like gangrene? Does this look like gangrene? Mesenteric ischemia. CA, yeah. You can call adenocarcinoma. Adenocarcinoma of the small bowel is rare. That's why you will put it as the last differential. Okay, please don't put it first. Strictures, ulcers, carcinoma can be seen in the small bowel, but they are rare. Why is adenocarcinoma rare in the small bowel? Not so common. Like you get adenocarcinoma in lower esophagus, stomach, colon, rectum. Why don't you get it in small bowel? Why is this rare? Kashala. Yeah, why is it rare? No stasis, very good. So understand overall malignancies in small bowel are rare because the contents are in constant movement. Small bowel is constantly moving your contents. They are always moving forward. So because there is no stasis, unlike in stomach where the pylorus gives you stasis, or in colon where the rectum gives you stasis, here there is no stasis. So direct insult is very less. If you get an adenocarcinoma in small bowel, what will you think? What will you think? If you get an adenocarcinoma in small bowel, what should you suspect? Yeah, golden question. What should you suspect if you get adenocarcinoma in small bowel? Secondary. Secondary from? Secondary from where? I like the way Advait is contributing to the class. He's making me also think. Intestinal obstruction plus secondary metastasis. From where? Small bowel में कहाँ से आएंगे secondaries? From colon, the cancer will climb up to the small bowel. Is it? Or a lymphoma? If there is adenocarcinoma in the small bowel, what should you think? Colon contiguous, very far-fetched. It has to be from the cecum going to the terminal ileum. Then you know it is coming from the cecum. Jejunum, let's say you did a biopsy of this specimen. Okay, this specimen, and it came adenocarcinoma. What would you think? What would you tell the patient? What would you advise the patient? I'll give you a simple case. Patient presenting with bleeding in stools. CT shows lesion in small bowel. Surgeon does resection anastomosis. Specimen shows adenocarcinoma. What will you tell the patient to undergo? What will be the next step? Yes, absolutely right, Nural. Thank you for saving face. And Mayuresh, adenocarcinoma in the small bowel is usually seen as a component of familial adenomatous polyposis syndrome. Because in there you will get villus adenomas in the small bowel also. Those can undergo malignant transformation. Varna rare. Okay. Overall, the most common malignancy in small bowel is adenocarcinoma, but it's still quite rare. These are far more common. Then the examiner will ask you, okay, doctor, what will tell me whether this is TB or typhoid? Why are you putting tuberculosis as first diagnosis and typhoid as third diagnosis? How do you differentiate TB from typhoid? This is second MBBS question. Okay, this is not final MBBS. Why are you calling this TB as first diagnosis? Why TB, not typhoid? Very good. So if your ulcer is transverse like this, it is going to be TB. If your ulcer are longitudinal ulcers, then it is going to be typhoid. This you know, second MBBS. Everybody knows this. So longitudinal versus transverse ulcers. Second thing you will say is they never form stricture. Obviously, they are going to be along the length. How are they going to stricture? When they will heal, things will come together here. But you can see in TB, because they are transverse, when they will heal, because they are circumferential, they will heal by fibrosis, they will form stricture. So strictures are seen only in tuberculosis, never in typhoid. Crohn's में भी दिखता है, of course Crohn's में भी दिखता है, पर टाइफॉइड में कभी स्ट्रक्चर नहीं होगा. So these can form stricture. Stricture is possible because they are circumferential. Stricture will be never. Okay, never you will get stricture in typhoid. Then the examiner will ask you, doctor, can you tell me management of the first patient, of the second patient, and of the third patient? If you answer this, and if you have been faring miserably in your previous Vivas, if you answer these three steps correctly, examiner will make you from fail to distinction. If you can answer these three things correctly. These are three different patients. First patient has a transverse ulcer, second patient has a transverse ulcer and a stricture, third patient has multiple strictures. How will you treat patient 1, patient 2, patient 3? From fail to distinction question this is. Okay, and from distinction to pass means if you can't answer correctly, you will go from distinction to pass. He will, lower your grade. First, no treatment. Wow, no treatment. Mayuresh, why would you say that? First, no treatment for just ulcers, anti-TB. Acha, okay. For just ulcers, anti-TB. Okay, anything else? First patient only ATT, very good. So first patient you should not be having any complication. You should only be having the ulcer. So in the first case, first one resection and anastomosis, second one stricturoplasty. No, Nurel, that is a disaster. That's not correct. In first there is no stricture. Why would you do resection and anastomosis? There is no indication for surgery. First patient will be medically managed. Second patient has a stricture, third patient has multiple strictures. The question I am asking you is, how do you treat single stricture? How do you treat multiple strictures? That is the intent of the question. So take a second guess. What will you do in patient 2? What will you do in patient 3? These are all specimen in your hospitals. I am telling you, 50% of you will have this specimen in your pathology lab. Any of these. Okay, so if there is a single stricture, I don't need to do resection. I can simply do stricturoplasty. In the third, where there are multiple strictures, I cannot do multiple stricturoplasties. So in this case, I will do resection and anastomosis. Are we very clear on this? If there is no obstruction, no complication for TB, we don't have to do surgery. ATT is the treatment. Single stricture, intestinal obstruction, just do stricturoplasty. No need to resect it unless the stricture is very long. Multiple strictures, I can't do stricturoplasty at multiple levels. I would rather do a resection and anastomosis. Okay, if you can answer till this, you are sorted. If you have been doing miserably, you will be saved. I'm telling you, these kind of questions will save you if you are drowning. Last part. First specimen, antemortem or postmortem, or can be either. Second specimen, antemortem, postmortem, can be either. Third specimen, antemortem, postmortem, can be either. 1 2 3. सी एक स्पेसिमेन में कितनी चीजें मिलती है. या इज द फर्स्ट स्पेसिमेन एंटीमॉर्टम और पोस्टमॉर्टम. सेकंड स्पेसिमेन एंटीमॉर्टम और पोस्टमॉर्टम. थर्ड स्पेसिमेन एंटीमॉर्टम और पोस्टमॉर्टम. फर्स्ट इज पोस्टमॉर्टम. Second is, okay, very good. Advait is saying first is antemortem. Excellent. Now he's saying, okay, sorry, postmortem. All Ira is saying all are postmortem. Oh, I so enjoy these kind of such variability. Enjoyable. PM, PM, AM. Oh, Rimi Sinha has come. Ruturaj, 1, 2 PM, 3 AM. Okay, sounds like a time where I should be taking classes. Definitely not 3 AM. As Mayuresh has suggested. Okay. I believe most of you have understood what I'm trying to ask you. Okay, I believe. First specimen, I told you treatment is only medical, so this resection is not the treatment. Definitely this is post-mortem. Okay, this is not the treatment of a single stricture. It's not even strictured, it's just an ulcer. Ulcer ko kyun main resection karunga? So definitely this is post-mortem. This one is a single stricture. This also could have been treated with stricturoplasty. Don't have to resect it. This is also post-mortem. This is the treatment. This is antemortem. So all those of you who said PM, PM, AM, absolutely right. Okay, absolutely right. Have no doubt about it. Okay, have no doubt about it. Let's move on. This is more of an exam specimen. This is not really an exam specimen. It is an ideal specimen. You won't get it like this. So let's stick to this one. Both are of the same disease. Okay, both are of the same disease. First, tell me organ. What is the organ? First, tell me organ. And then tell me lesion. ऐसा स्पेसिमेन एग्जाम में मिलेगा. गुड इवनिंग सबा. ऐसा स्पेसिमेन एग्जाम में मिलेगा, ऐसा नहीं मिलेगा. ये तो जस्ट निकाला हुआ स्पेसिमेन है. यू आर नॉट गोइंग टू गेट ऑल दिस ब्लड एंड ऑल इन द स्पेसिमेन. यू आर नॉट गोइंग टू बी सो लकी. या व्हाट इज द ऑर्गन? Small bowel, colon. If small bowel, which part? If colon, can you tell which part? Cobblestone, small bowel or colon? Ira is giving both the answers. Small bowel. Why Mayuresh small bowel? Sir, I am so late. Late with an LAIT. It's like a coffee, cafe au lait. Mostly jejunum. Every time, mostly jejunum. Colon. Thank you. That's exactly what I wanted to hear. What Ira has just said. First, I would like to see outer surface. First, I would like to see outer surface. Okay. So, please see the outer surface, because in the outer surface of both of these specimens, outer surface is suggestive of small bowel. Means there are no hostrations, no tinea, no appendices. So this is small bowel. And you see so many plicae. Probably this is jejunum. Probably. Not sure, can't say for sure, could be jejunum or ileum. What are you seeing? Yeah, what do you see? So this is a cut open specimen of small bowel. Outer surface appears normal. Cut surface shows what? Exam specimen, eh? Multiple small polyps. Okay. You will say multiple polypoidal lesions. Anything else you would want to add apart from the fact that there are multiple polypoidal lesions? Any other terminology in the description? Yes, these are multiple polypoidal in this area. You will see a few polypoidal lesions in this area also. Pseudo polyp, वो ग्रॉसली नहीं समझ में आएगा कि ट्रू पॉलिप है या सूडो पॉलिप है. Loss of plique, yeah, where there are the polyps, those you can't, where you can't see the plique. Take a leaf out of this specimen also, they are both the same. You see multiple polypoidal lesions here, discontinuous, absolutely, with skip areas. Exactly what I wanted to hear, skip areas. Like this part is normal. So you see these polypoidal lesions here, this part is normal, this part is normal, this part is normal, whether TK are looking normal. This part is all normal. थोड़ा इधर polyps है, यहाँ पे ज़्यादा polyps है, with skip areas in the small bowel. What is your diagnosis? Yes? What is your diagnosis? Crohn's. अच्छा. Any other? एक तरफ you are saying polypoidal lesion, दूसरे तरफ you are saying Crohn's. Would you like to change polypoidal lesions to anything else? Okay, so if I were you, I would give a differential diagnosis. I would say this could be Crohn's disease. This could be familial adenomatous polyposis syndrome also. Alright, and when I'm describing this polypoidal lesion, I would say with cobblestone appearance. Then the examiner will ask you, doctor, why are you saying Crohn's as first diagnosis and FAP as second diagnosis? What will be your answer? Should it be FAP in 1 and Crohn's number 2? Or Crohn's number 1, FAP number 2? What in this goes in favor of Crohn's or in favor of FAP? उतना बड़ा अल्सर इज सर्पेंट लाइक, नो, इतना वो अल्सर सर्पेंट लाइक नहीं है. FAP in colon, FAP small bowel में भी होता है यार. In FAP you get polyps in colon, in small bowel, duodenum, stomach में भी होते हैं. Everywhere you get adenomas. So it's not necessarily restricted to colon. Yes, there are thousands in colon, but they are there in small bowel also. Could be Peutz-Jeghers also. Peutz-Jeghers you get hamartomas. Crohn's are ulcer. You can't say for sure, na, these are ulcers. Cobblestone is characteristic. Cobblestone तो मैंने बताया. You didn't even utter cobblestone. Crohn's first, SAP 100 and continuous. Okay. With this much info, first FAP. Okay. So FAP is usually going to be continuous. And Crohn's is going to have skip lesions. But these are not hard and fast rules. FAP can have skip lesions. There may be so much crowding, so you can't say for sure. Okay, you can't commit for sure. Then the examiner will ask you, then how do I differentiate Crohn's from FAP? If the specimen looks the same, how do I differentiate Crohn's from FAP? Yeah. How will I differentiate? Whether this is Crohn's disease or whether this is FAP. Yes, anybody? Histopath, per histopath mein, how do I get the histopath? How do I get the histopath? Please remember, this is small bowel. All of you have committed. This is small bowel, probably jejunum or ileum. Okay. How will you get the biopsy? Colonoscopy will go in the jejunum. Colonoscopy will go in the jejunum to get the biopsy. Oh, yeah, exactly. So how do I differentiate whether this is FAP or Crohn's? Is there any way? Pre-operatively, don't say surgical excision and histopath. Creeping fat, again, for that I'll have to do diagnostic laparoscopy. Serosa will be involved, diagnostic laparoscopy. Any non-surgical way? Can colonoscopy give the answer? Okay. Since Advait mentioned colonoscopy and now he has retracted the message, can colonoscopy give the answer? Genetic. Okay, but उसके लिए मुझे जीन टेस्ट करनी पड़ेगी, वो तो मैं करता नहीं हूँ. Can colonoscopy give the answer? FAP is genetic, that is correct. So remember, in FAP, colonoscopy will have at least 100 polyps. In Crohn's, colonoscopy can be normal. Okay, colonoscopy can be normal. What I'm trying to say is, if your disease is in the small bowel, you don't have to go to the small bowel to get the biopsy. For FAP, the biopsy will come in colonoscopy. Mayuresh, Crohn's में bleeding नहीं होती. Bleeding is more in ulcerative colitis. Crohn's does not have bleeding. FAP can have bleeding. So clinically they can't be segregated. Both present in young population. Crohn's has bimodal distribution, 20s, 30s. FAP also is present first decade, second decade of life. Crohn's doesn't have blood. Colonoscopy will give the answer. In FAP, you will have more than 100 polyps in colon. You take a biopsy, you will get villus adenoma. End of the story. Crohn's may or may not be involved. If it is involved, if you are lucky, you can do a biopsy. Biopsy will show what in Crohn's? What is the histopathological hallmark of Crohn's? Yes. What is the pathological hallmark of Crohn's? Pathological hallmark of Crohn's? Yeah. Crohn's pathology. You are lucky your patient had some ulcers in the colon or in the terminal ileum. You did a biopsy. What will it show? Transmural. Transmural to ठीक है. It will show non-caseating granulomas. Non-caseating granulomas. How will you confirm it is Crohn's? You see non-caseating granulomas. वो तो tuberculosis में भी दिखते हैं. Why is that not tuberculosis? Why is this not tuberculosis then? Why are these ulcers not tuberculosis? Yeah. So why is this not tuberculosis? Ask antibody. Antibody is non-specific. Biomarkers. Difficult. Anything better than a biomarker? Anything better than a biomarker? Anything I will check in the stool? All exam questions I am giving you. Constitutional symptom. Mayuresh, you are being very optimistic that your patient will be a thin patient who will say I have evening rise in temperature and cough with expectoration and TB in the past. ऐसे patient नहीं मिलते. Real world में नहीं मिलते. What will I see in the stool? I will look for calprotectin. Calprotectin is a marker of IBD. Okay, one of the ways of differentiating Crohn's from TB. Calprotectin. Rectal sparing. Rectal sparing is seen in both Crohn's and TB. Anyways, this is what I wanted to show you. This is how colon looks. So hostrations of the colon are like this. These circular folds. These are the colonic hostrations. This band that you see, this is your tinea coli. Okay, and these fatty appendages that you see, they are your appendices. Okay, they are the hallmark of colon. They are seen throughout the colon, whether it's cecum, ascending colon, descending, transverse. पूरे colon में tinea, appendices, hostrations will be seen. Hostrations can be lost Okay, you can have loss of ostrations if he has ulcerative colitis. Tinea are not going to go anywhere. Okay, nothing will happen to the tinea. So tinea to tumko dikhenge. So please, for God's sake, when you get an exam specimen, first look at the outer surface. If you see tinea coli, it is going to be colon. Don't see tinea coli, don't see ostrations, call it small bowel. Safe bet. Okay, safe bet. Jejunum ileum differentiation is difficult. That the examiner will agree. Anybody can tell me? Yeah, lead pipe. Anybody can tell me whether this specimen is ante-mortem or post-mortem? This is ante-mortem or post-mortem? I'm not asking this one because it's a little misleading. This specimen, is it ante-mortem or post-mortem? I think from now on, whenever you will study any specimen, the first question you will ask yourself is ante-mortem or post-mortem. And there is a third option, cannot be decided. So Mayuresh says post-mortem, Saba says ante-mortem. Please don't be misguided. Okay, Advait has given a very excellent answer. Your answer should be this is post-mortem, because the treatment of Crohn's is limited resection. You will avoid resection wherever possible. This probably is ante-mortem because this is a bleeding. So maybe it was excised for bleeding. But that's rare. That's why I said don't go by this. ऐसा specimen exam में नहीं आएगा because you can't see bleeding. But this you can make out. You just see this cobblestone mucosa here and little bit over here. Why should you excise it? Unless there is obstruction, perforation, strictures, don't excise Crohn's. The treatment of Crohn's is always going to be limited resection. Limited resection. Please do not resect in Crohn's. Patient will land up with short bowel syndrome. You will keep on resecting, he will land up with short bowel syndrome. Exam specimen. Yes, what is this? If it's FAP, if what is FAP? FAP what? I didn't get your question if it's FAP. Anyways, this specimen. So you can see even from the outside, you can see these appendages. Yeah, you can see these appendages. So this you will say is a cut section of colon. Okay, you don't need the tinea coli, assume they are there. Okay, tinea coli are going to be there. These are appendices epiploicae. So this is a cut section of colon. What is it showing? Classical exam specimen. If it's FAP, will it be AM or PM? FAP में small bowel exercise नहीं करते. Okay, FAP में you do proctocolectomy, not small bowel resection. Okay, yeah. Coming to this, it shows bluish discoloration. When I show you a lion, look at the head of the lion and not the tail. This is a specimen. You can't see gangrene in a specimen. I'll give you a clue. Mayuresh, look at this. Why have I cut open the bowel? Because I want you to see the inside. What are you seeing on the inside? What is this? What is this? I've cut it open to make you look at the mucosa. This is, see, I told you. ऐसा नहीं है कि colon में plicae नहीं होते. You can see now the plicae are there. They are less. They are sparse. But they are there. So plicae के नाम पे मैं colon और small bowel को अलग नहीं कर सकता. तो ये क्या चीजें हैं? ये और ये. Exophytic growth. Excellent. This is a cut section of the colon showing a polypoidal lesion. Polypoidal lesion or exophytic lesion. Excellent. Absolutely correct. What is your diagnosis? What is your diagnosis? Yeah. What is your diagnosis? CA colon. Anything else it can be apart from CA colon? CRC. What is CRC? Colorectal cancer. Ira. If you are calling it colon, then your diagnosis cannot be colorectal cancer. Okay. examiner will jump on you when you will give an answer like that. You called it colon. You didn't call it rectum. So how can you say colorectal? Gastrointestinal stromal tumor. Acha. Gastrointestinal stromal tumor are submucosal. Okay, they are submucosal. They cannot be seen from inside. Polypoidal lesion नहीं होता वो. So you one answer you are giving is CA colon, and then I will ask you which part. Can you guess cecum, ascending, transverse, flexure, descending, sigmoid? Okay. Any other differential apart from CA colon? Are you sure this is CA colon, or can it be anything else? It's not a gist, mind you. Gist is submucosal. Gist cannot be seen from the mucosal side. This is the mucosa. Can it be pseudo polyp? Where do you get pseudo polyp, Mayuresh? I'm so happy I'm taking this class. I'm so happy you guys are speaking, because I can see you guys are speaking infuriating things. Ira saying Peutz Jagger. Ira, Peutz Jagger affects what? What do you get in Peutz Jagger? Mayuresh is saying pseudo polyp. You have a pathological eyes, like a histopathologist. वो polyp देख के बोलेगा ये Peutz Jagger है या वो pseudo polyp है. I should have kept the picture of pseudo polyp. Anti-mesenteric side. My dear, this is colon. Forget the mesentery. Okay, forget about mesentery. This is colon. There is no mesentery. I should call all of you guys who are in the chat to my house and take these class face to face. I really feel like doing that. Talking to you face to face. And then pulling your ears. Where are the diverticulae? Saroj, diverticulae kahan hai? This is a diverticulum. You're calling it a polypoidal lesion. Diverticulum kahan se hua? If I were your examiner, on every word that you guys are saying, I would catch you. And I will keep pulling you. Keep pulling you, pulling you, pulling you. Be very careful when you commit these things. Pseudo polyp. Okay, first things first. फिर क्या होगा? No name, nothing. Thank you, no name, nothing. Okay. Peutz Jagger. What do you get in Peutz Jagger? You get hamartomas. Okay. You get hamartomas. Where do you get hamartomas? Small bowel. Is this small bowel? No. Colon में ज़्यादा hamartoma नहीं होते. Usually small bowel में होते. Okay. Then Mayuresh said pseudo polyp. Mayuresh, what are pseudo polyps and where do you see pseudo polyp? Pseudo polyp is seen in which disease? Pseudo polyp कौन से disease में होते हैं? They are seen in ulcerative colitis. Is this ulcerative colitis? Is this continuous? Ulcerative colitis has to be continuous. Is this continuous? No, you just see one lesion over here. How the hell will it be continuous? How can it be pseudo polyp of ulcerative colitis? Okay, pseudo polyps are nothing but the part between the ulcers where the mucosa hypertrophies. So you will see continuous ulcers and beach ka part will show the polyps, which are pseudo polyps. The other differential is it can be a benign polyp. Bus. Why are you calling this? Because isolated benign polyps are rare. That's why second. It can be a benign polyp. Nothing. Then the examiner will ask you, please, this cannot be anything else under the sun. Please don't call this pseudo polyp. This is not pseudo polyp. This is not hamartoma. Single hamartoma in colon is extremely rare. Hamartomas are multiple. They are usually in the small bowel or colon as a part of Peutz Jagger. No. Why will we resect? That question is yet to be answered. Is it antemortem or postmortem? So Koyal, don't jump the gun on that. Why will we resect a benign polyp? Let's not jump the gun. This is your differential. Whether you will resect it or not, that is secondary. Fine. Then the examiner will ask you, okay, YouTube gives you the chance of retracting, but in real life you cannot retract. Sir, please say, sir, kal hai aapka class? Yes, kal hai meri class, same time pe. Okay. Then the examiner will ask you, doctor, which part of the bowel do you think this polyp or polypoidal lesion is arising from? Yeah. Which part of the bowel or colon do you think this lesion is from? Because from outside and inside I can't say na, whether it's cecum, ascending colon, transverse colon, hepatic flexure. Which part do you think this is? Yeah, which part do you think this is? Ascending colon. Why ascending colon? Why ascending colon? Very good. Nural is saying descending, Advait is saying ascending. Anybody wants to say transverse colon? वही रह गए. Mayuresh, yes, transverse colon. Second MBBS pathology. This polypoidal lesion that you are seeing. Can it be in transverse colon, ascending colon, or descending colon? Yeah, ascending colon. Yeah, it is going to be ascending colon most probably, because right-sided masses are polypoidal, left-sided masses are constricting. So right-sided masses are polypoidal, left-sided masses cause napkin ring constriction or apple core constriction, either like a napkin ring or like an apple core. So it goes like this. Usually, but this is usually. If you are asked this question, he is intending to mean this. This will be on the right side, polypoidal lesion. Left side will be constricting lesion like this. Because probably believed to be because of the consistency of the stools. So you get a napkin ring or an apple core region on the left side. But this is not hard and fast. It's not hard and fast. Okay, last question. This is specially for Rimi Sinha. Antemortem or postmortem? Assuming this is a adenocarcinoma. Now don't say why will we resect an adenocarcinoma. I have resected the adenocarcinoma. Adenocarcinoma तो resect ही करते हैं. Antemortem or postmortem? Or can be either. Postmortem. Yes. Yes, Rimi, what's your answer? I'm curious to hear your answer because benign polyp you don't want to excise. Malignancy would you excise? Ira and Rimi are saying antemortem. Acha. Anybody for cannot be commented, can be either. Aha, Mayuresh has set the cat among the pigeons by making that comment. Treatment is right hemicolectomy. That right hemicolectomy if it is in the cecum or ascending colon ना. Transverse colon में भी हो सकता है. PM तो कोई भी हो सकता है. No. Ira, if that is your answer, then you should say, sir, it could be antemortem or postmortem. If you want to play it like that. On which the examiner like me will absolutely grab you by your throat and say, how can you give such an answer? PM तो कोई भी हो सकता है. Exactly. This is probably postmortem. This is probably postmortem. Please understand the treatment of a colonic cancer is not a wide local excision. You do colectomies. Like on the right side, you will do a right hemicolectomy. So a specimen of a right-sided tumor, if the tumor was over here, should not only have ascending colon, it should also have transverse colon, it should also have cecum, it should also have terminal ileum. Should also have terminal ileum. If it's in the transverse colon, it should also have more of transverse colon. This is a wide local excision specimen. Who does wide local excision for colonic cancers? So most probably it is postmortem. Most probably. Can be antemortem if this is a sigmoid tumor and only a sigmoidectomy was done. But unlikely. And at least there should be some mesocolon, some mesentery, some lymph nodes. वो भी नहीं दिखा रहे. Lymph nodes तो दिखने चाहिए. You are calling it malignancy and then you are doing a benign resection. If this was a GIST, which it is not, because GISTs are submucosal, then this is acceptable treatment. But for adenocarcinoma of colon, this is not an acceptable treatment. I am not saying this is in actuality a post-mortem specimen. I am telling you how you are going to answer. Okay, how you are going to justify. And you will never say post-mortem koi bhi ho sakta hai. If you say that, examiner says, okay, you are just trying to beat the question. You have to show you understood that probably this is post-mortem because this does not look like the treatment of an adenocarcinoma. Because for an adenocarcinoma, I do colectomies depending on the site. This is not looking like a colectomy specimen. It's looking more like a wide excision specimen. Fundamentals have to be clear. Okay, fundamentals have to be clear. Otherwise, gadbad. So we'll do some procedures now. Yesterday we did open chole. We'll quickly do lap cholecystectomy. It's not very difficult since we did open cholecystectomy yesterday. We will do lap cholecystectomy today. So first will be what is the procedure? That is the definition. So it is a laparoscopic removal of gallbladder. Indications same as open cholecystectomy. So it can be GB stones. This is the treatment of choice for gallstone disease. CAGB, but in CAGB you don't do lap cholecystectomy, you do radical cholecystectomy. Okay, you do radical cholecystectomy. Contraindication, very sick patient, unfit for anesthesia. We discussed this yesterday. You will do a percutaneous cholecystostomy. This is what we did yesterday. Cholecystostomy, percutaneous, and then do lap cholecystectomy later. Then you do the steps. This is what we need to do briefly, not in details. Okay, briefly. All lap procedures, anesthesia, universally you will say general anesthesia. Okay, don't spend any thought process. स्पाइनल में कर सकते हैं लैप कोलेसिस्टेक्टमी, पर प्लीज वो एग्जाम में मत बोलना, बिकॉज इट इज नॉट स्टैंडर्ड प्रैक्टिस. Okay, it is not standard practice. Standard practice for all lap procedures, whether it's cholecystectomy or appendectomy, it is going to be done in general anesthesia. Standard practice. Then incision. Position is supine, incision. Now understand, whenever I start any laparoscopic surgery, the first step of laparoscopic surgery is what is called as creation of pneumoperitoneum. It is creation of pneumoperitoneum. What is pneumoperitoneum? Understand, when I am doing a laparoscopic surgery, okay, what I have to do is I put instruments into the abdomen and do the surgery with the help of a camera, but I need to create the space. What space is this? This is the space. If you look from the side, this is your abdominal wall. Okay, inside is your bowel, for example. Okay, and I'm going to put my instruments through the abdominal wall like this and go wherever I have to do the surgery. So I need to create a space between the abdominal viscera and the abdominal wall. This space is created by filling the abdominal cavity with CO2. Yes, that's right, CO2. So what I do is, the first step of any laparoscopic surgery is creation of a pneumoperitoneum, means fill the peritoneal cavity with air, but it is not air, it is with CO2. Why CO2, Advait? Why CO2? Why not air? Can I use air? Is it a problem if I use air? Or I must use CO2? Any problem with air? You specifically mentioned CO2. ऐसा क्यों? Can I use air? Air is easy ना, cheaper. बाहर से हवा है, उसको मैं एक सिलेंडर में कलेक्ट करके एब्डोमेन में डाल दूंगा. CO2 has to be factory produced. So why CO2? Any problem with air? Yeah. Cautery, what about it? Air has O2 also, 20%. So what's the problem with 20% O2? Inert to elect. Air is also fairly inert. Air can be used but flammable. Air is flammable. Air is flammable. Ruturaj, why is air flammable? Okay, any other answer? Inert to elect. Okay, see, the first answer that you are going to give, the first answer is CO2 is rapidly excreted. This is the first answer you're going to give. Understand, whatever air I fill in the peritoneal cavity, it gets absorbed from the peritoneal surface. Okay, it gets absorbed from the peritoneal surface. If it's CO2 that gets absorbed, it will be excreted rapidly in his breath. Okay, because he will be on ventilator. Rapid excretion. Air obviously will take time. Second risk is air embolism. This CO2 this air that is put in the peritoneal cavity is air under pressure because the abdomen has to be bloated. It's under pressure. If there is any open vein, the air will rapidly enter the vein and he will get air embolism. Whatever is absorbed is excreted. Okay, whatever is absorbed, पहले absorb होना चाहिए, फिर excrete होगा. सारा absorb नहीं होगा. Do we keep giving? Yes, we keep giving. Some CO2 leaks also. Second is air embolism, and third is CO2 is non-conducting or non-inflammable. Yeah, air is conducting, oxygen is flammable, but तुम अंदर कौन सा ये फटाके थोड़ी जला रहे हो कि कुछ फटने नहीं वाला है, ऐसे आग नहीं लगेगी अंदर if there is air. So it's not that you can't use air. CO2 is better. Okay, CO2 is better. You can use cautery in air, there is no problem. Yeah, theoretically it is conductive, CO2 is non-conductive, पर ऐसा नहीं है कि अंदर फटाका फटने वाला है. So that should be your last answer. First answer, rapidly excreted. Whatever gets absorbed, rapidly excreted. CO2 embolism नहीं होता because CO2 gets dissolved in the blood and gets excreted in your breath. Chances of CO2 होता है CO2 embolism, but much less. Chances are much less. So that's why CO2. But air is not contraindicated, is what I'm trying to say. Okay, air is not contraindicated. पहले ज़माने में air use करते थे, ऐसा कुछ नहीं है. So first, what I have to do, I have to create a pneumoperitoneum. Okay, yes, of everything is under pressure, but if it's excreted fast, even if there is air embolism, it won't stay. The bubbles will be very small. So first, what I do to create a pneumoperitoneum is I use this instrument. Anybody can tell me what this instrument is? Very important instrument. This instrument is called what? Very good. Thank you, Nurel, for maintaining decorum where the others are going all over the place. This is called Verey's needle. No, they will not ask you. At least I don't know, besides air and CO2, what else is used. At least I don't know what else is used. There is laparoscopy where you can do without any air also. It's called gasless laparoscopy, but let's not discuss that here. So this is a Verey's needle. Now a Verey's needle is nothing but the first needle that I put in the abdomen, and it will go through all the layers. Okay, it will go through all the layers. ऐसे डालता हूँ मैं उसको. The tip should be intraperitoneal. Just the tip has to be intraperitoneal. I put it blindly. Okay, it's not under vision. It's by feel. I put it blindly. So I input the Verey's needle through the skin, subacute, muscles, peritoneum, intraperitoneal. Once the Verey's needle is inside, this is called closed technique. Where I use a Verey's needle, it's called closed technique because I am not seeing, I am putting it blindly. And then to the upper end, I attach a tube from which I put the CO2. So I create the pneumoperitoneum. This is called closed technique using Verey's needle. Once I create the pneumoperitoneum, means there is a big gap between the bowel. Bowel goes down, अंदर छुप जाता है, नीचे abdomen comes up, and there is a big gap. Then I remove the Verey's needle. It doesn't have to be there. And then I put these trocars or ports. They are cylinders, hollow cylinders that I put in the abdomen, through which I will put the camera, through which I will put my surgical instruments and do the surgery. So after the space is created, this is the starting of all laparoscopic surgeries. I put one trocar or a port from the umbilicus. I put one from say over here, one over here, one over here. I'm talking about cholecystectomy. In cholecystectomy, I put ports like this. One at the umbilicus, one at the epigastrium, one in the mid-clavicular line, one in the anterior axillary line. They form like a right angle triangle, sort of. I put these 4 ports. From one port, I will put a camera to see inside. From the other ports, I put my surgical instruments. I see on the TV and I do the surgery. So I am seeing everything outside as my instruments are going inside, and it looks a bit like this. Okay, it looks like this. So I see the gallbladder, one instrument, I push the gallbladder up. Remember yesterday when we did open cholecystectomy, we held the fundus with a sponge holder, right? We held the fundus with a sponge holder. अभी laparoscopy में sponge holder नहीं होता, laparoscopy में you have instruments, they are called graspers. So with the help of a grasper, I push the gallbladder up. Just like I did an open cholecystectomy, same way, I push it up. As you can see, when I push it up, gallbladder goes up and this area gets exposed. Yes, what is this area? What is this area which is getting exposed? That is going to be my focus of the surgery. Yeah, anybody? Very good. I expose the Calitz triangle. So this is the liver. The gallbladder has been pushed up with one instrument. Now I start the surgery just like I did an open cholecystectomy. With one instrument, you can see over here, I hold over here and pull it laterally. This in open surgery we use sponge holder again. Remember we use 2 sponge holders in open surgery. Here also I use a grasper and I hold over here. What is this area where I am holding and pulling it laterally? Pull it over here in this direction, either pakad ke. What is this area that I hold to make this triangle better exposed? Yeah, what is this that I'm holding? And I pull it laterally. In open surgery also I did the same thing, but I used a Hartmann's pouch. Excellent. See, very soon you guys will be able to do all these surgeries on your own. It's called Hartmann's pouch. I expose the Calitz triangle. Then it's very easy. All I have to do is I dissect in this Calitz triangle. After I have dissected, I see these 2 structures in isolation. The lower structure is probably the cystic duct. The upper structure is the cystic artery. बस ये 2 चीजें मुझे देखनी है. This that I see, cystic duct, cystic artery, this appearance, anybody knows what this is called? The most important step. When I see the cystic artery, I see the cystic duct, I can see a little bit of the liver behind in the background. What is this called? Excellent. That is called critical view of safety. Once I get the critical view of safety, I put clips on the duct and artery, I cut them, and I remove the gallbladder. End of the story. Okay, put clips. In open surgery we put sutures. Here we are putting clips. Cut the artery, cut the duct, and remove the gallbladder. End of the story. Then close all the ports that you put. All these ports that I put, then I just close them. Skin on the upper side. This is lap cholecystectomy. Seems easy. Okay. End of the story. Then complications are going to be the same. Like we did complications of cholecystectomy, here also complications are going to be the same. The important complications, early and late. Early was bile leak and late was stricture. causing obstructive jaundice. बस काम के complications यही है. Both of these come under a common group called bile duct injury. Okay, let's move on. We'll do one more procedure, interesting one, that is appendicectomy. Now the thing with appendicectomy is, unfortunately, they expect you to know everything about. Cholecystectomy तुम थोड़ा ऊपर नीचे कर लो तो चलेगा. Appendicectomy you need to know in detail. And if you know everything in detail, it's like a hernia case. सब आया तो एग्जामिनर बोलेगा ठीक है, एक्सपेक्टेड है, hernia appendix तो आना चाहिए. और कुछ नहीं आया तो don't know appendicectomy also, big deal, big problem. So we will try to make it simplified. At least the expected questions we will discuss a little bit in detail. But we'll do it in the same protocol how we do all our procedures. So first is, what is the procedure? So appendectomy or appendicectomy again is going to be surgical removal of appendix. Okay, first we are going to do open appendicectomy. Lap appendicectomy is going to be done the same way as you did cholecystectomy. Principally it's the same. Anybody indications for appendicectomy? Like you have for gallstones, one is appendicitis. Any other indication for appendicectomy apart from appendicitis? Any other? Failure of conservative, वो तो appendicitis में ही होगा ना अद्वैत, appendicitis ही हुआ वो. Failure of conservative. Carcinoid tumor more than 2 centimeters. Carcinoid tumor involving the base. Dangerous answers. Absolutely dangerous answers you guys are giving. For now, just write tumors. Just write tumors. Don't write the size. Size I will tell you. And the third is as a part of other procedures like LATS procedure. और राइट हेमिकोलेक्टमी में मैं अपेंडिक्स नहीं निकालता हूँ ना, वो तो अपेंडिक्स आ जाता है, मैं अपेंडिक्स नहीं निकालता हूँ. इट कांट बी कॉल्ड एज अपेंडिसेक्टमी. ओके, लैट्स प्रोसीजर में आई रिमूव द अपेंडिक्स. देन देयर आर सम बेरियाट्रिक सर्जरीज वेयर आई रिमूव द अपेंडिक्स. डिओडेनल स्विच उसमें आई रिमूव द अपेंडिक्स. सो दीज आर वेयर आई रिमूव नॉर्मल अपेंडिक्स. ट्यूमर का साइज करना है. एनी कॉन्ट्राइंडिकेशन for appendicectomy? Important question. Mucocele. No, why will I not remove appendix? I am asking you contraindication. Mucocele is a part of appendicitis only, the spectrum of appendicitis. Any situation where I don't remove the appendix. ये तुम बताओगे तो एग्जामिनर को लगेगा कि हाँ भाई तुमने समझा है what the disease is, you have understood. Septic patient, वो कोलेसिस्टेक्टमी के लिए ठीक है क्योंकि वहाँ दूसरी ऑप्शन है. यहाँ क्या ऑप्शन है? सिक पेशेंट. सिक है एंड इट्स द अपेंडिक्स विच हैज परफोरेटेड, यू मे हैव टू रिमूव इट ना, एटलीस्ट पुट अ ड्रेन. बेटर आंसर, you can say sick patient, but no, in gangrenous appendix you should remove the appendix. Don't wait for it to cause peritonitis. So I will accept sick patient, but that is the second choice. Sick patient because of gangrene of appendix. But ideally you should remove the appendix. Anesthesia related, no. Assuming it's not anesthesia related. No, but we do hemicolectomy. Let's not go there. Appendicular mass, excellent. Saroj, Vishaka, excellent. This is the answer. Appendicular mass or appendicular phlegmon, both mean the same. Phlegmonous appendicitis, where the inflamed appendix has been sealed off by momentum, small bowel, and has formed a lump. Okay, and it has formed a lump. This is the contraindication. तुमने ये बोला नहीं बोला कुछ फर्क नहीं पड़ता, but this is the contraindication. If the person has a phlegmon, don't attempt appendicectomy. Okay, in this case, what do you do? If he has an appendicular phlegmon, what do you do in this case? three of you gave this answer. Then if the person has an appendicular mass, what do you do? करेंगे क्या? Yes. Saroj, Vishaka, 106, Mayuresh, ओके, ओनर, ऑस्नर शैटर, ऑस्नर शैटर, अरे कितना तुम लोग नाम घुमा रहे हो, मैं ही भूल जाऊंगा. ओके, प्लीज राइट द नेम करेक्टली, तुम लोग गपला कर रहे हो. इट्स कॉल्ड ऑस्नर, ऑस्नर, नहीं अरे शेरिंगटन पेरिंगटन, क्या नाम लगा रहे हो तुम लोग. ऑस्नर शेरन, सब ने अलग नाम बोले, नूरल ने सही नाम बोला है. इट्स ऑस्नर शेरन. ओके, ऑस्नर शेरन, वो शेरिंगटन नहीं है. और भी किसी ने कुछ नाम दिया था, वो ऑर्थोपेडिक नाम बोला था, ऑसगुड शैटलर. इट्स नॉट शैटलर, वो ऑर्थोपेडिक में होता है, ऑसगुड शैटलर डिजीज. ऑस्नर शेरन, आई नो देयर आर टू मेनी नेम्स, आई अंडरस्टैंड, life is tough at an MBBS level, I understand, but some names you have to know. Otherwise, forget the name. Go the way Ira said, conservative management, or Vishaka said, conservative management, safe. Okay. What is this Osner Sharon regime? Anybody? What do I do in Osner Sharon? Conservative management means what? करना क्या होता है मुझे? Patient को बोलूँगा घर पे बैठ. करना क्या है मुझे? What is Osner Sharon regimen? BOO. What is BOO? NPO. Okay. Anything else? NPO. Antibiotics. Very good. Anything else? It is nothing but conservative management, but basically just like our emergency management. It's basically a little less than our emergency management. Basically analgesics. Okay, I'll tell you, easy way to remember. This is what you will tell. F, 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 F. First F is fasting or nil per oral. Second is give him IV fluids. Obviously, if he is fasting, you will give him fluids. Third is fomentation. You give him hot fomentation so that the spasm and the pain reduces for pain. The fourth F is called Fowler's position. And the fifth F, anybody can guess the fifth F? It's a little outrageous. That's why 4 Fs are correct. The fifth F is a little outrageous. Anybody can tell me what is the fifth F? It's a little outrageous. Whoever has created these 5 Fs has really thought imaginatively. It is a equivalent of antibiotics. Anybody? What is the fifth F? It's for antibiotics. It stands for antibiotics. Nobody? Who discovered penicillin? Who discovered penicillin? Mayuresh has tried floxacillin. No, it's not. It's more outrageous. Who discovered penicillin? Fleming. Yeah, so it is Fleming's penicillin. No, not Edward Jenner. Ira, it's not Edward Jenner. Edward Jenner, I think, was smallpox vaccine. Mayuresh is really having a laugh today. He's enjoying everyone's comments, including his own. Basically, you're going to do conservative management, antibiotics, NPO, fluids, fomentation, Fowler's position, monitor the lump, monitor his vitals. He should not become febrile and all those things. Monitor the size of the lump. Lump should not increase in size. And after this, you will do interval appendectomy. After the lump resolves. After the lump resolves, you will do interval appendectomy. Okay, ये हो गया मेरा contraindication. Now we will do steps of appendectomy. We are talking about open appendectomy. So first thing is the anesthesia. Anesthesia for open appendectomy can be spinal. 1 month, yeah, 4 to 8 weeks. Fowler's position is basically the bed is placed in a certain way. Normally the bed is like this. If this is the head end, let's say this is the head end, the bed is like this, a flat bed. Fowler's position mein the bed is placed in a certain way, where the head end is like this, head end of the bed, and the middle part is like this, and the tail end is like this. So it's sort of Z shaped, and the person lies like this, lies on the bed like this. This is Fowler's position. Yeah, semi-seated, sort of semi-seated. So in this position, the lump remains localized by gravity. So basically his abdomen comes in the dependent position and the inflammatory substances remain localized. They don't spread. So the peritonitis will not happen and the lump will remain localized. That is Fowler's position. Anesthesia is going to be spinal or general anesthesia. Any can be used. First thing is the incision. Most of the times the examiner will be happy if you can tell the incisions correctly. Yes, anybody? What are the incisions for appendectomy? First step is going to be this. Most of the times examiner सिर्फ आपको incision पूछ के छोड़ देगा और कुछ नहीं पूछेगा. He will not really wait for you to tell the steps. Yeah. Yes, anybody? What are the incisions? 1, 2, 3, 4, 5. McBurney. Any other? 4, 5 incisions are there. सबने McBurney बोला, gridiron बोला, Lands. Okay. Any other? 4 incision तो आने चाहिए. Rutherford, very good. Midline, very good. Gridiron and Rutherford Morris. Okay. आप सब ने जिसने McBurney बोला, means none of you have read Bailey. There is nothing like McBurney incision, unfortunately. Okay, so let us be very clear. There is no McBurney incision. The name of the incision, anybody, which we believe as McBurney, there is nothing like McBurney. The name of the incision is, yes, Vishaka, it's Macarthur. Thank you. It's Macarthur. Okay, ये जो Macarthur है, that is also called as gridiron. Both are the same. Okay, they are the same. Macarthur or gridiron. It's not McBurney. It is centered around McBurney's point. Okay, McBurney did not describe the incision. The incision is described by Macarthur. You don't trust me? Open Bailey and Love and see it. I can show it here also. It's open right now. The incision is called Macarthur. Macarthur described the incision. What is the incision? This is your ASIS. This is your umbilicus. You join the two. This is your spino-umbilical line. 2/3, 1/3. 2/3 medial, 1/3 lateral. This is my McBurney point. The incision is centered around McBurney point and perpendicular to this line. So it is perpendicular to the spino-umbilical line at McBurney's point like this. This is Macarthur incision. The second incision is where I go a little more lateral for more exposure. I go a little more lateral. What is the name of that incision where I go more lateral? It is called Rutherford Morrison incision, also called as Weir's extension. Okay, Rutherford Morrison or Weir's extension, where I go a little more lateral. I'll tell you what the difference is between the two. This incision is required if the McBurney incision or the Macarthur incision is not adequate. मुझे उसमें enough दिख नहीं रहा. What is the basic difference? I'll tell you when we discuss the incisions, means when we discuss the surgery. These are the two main incisions. The third incision is Lance incision or Lance's skin crease or bikini incision. It's a skin crease incision. It's a elliptical incision in the right iliac fossa at the skin crease. जैसे यहाँ पर Phanon stele होता है, वैसे laterally in the right iliac fossa is Lanz's incision. It's a cosmetic incision. It's a skin crease incision. ये लिखा ना Weir's extension, Fowler Weir or Weir's extension. So this is the third incision, and the fourth, of course, is going to be midline incision. Okay, these are the four main incisions. Then the examiner will ask you which incision you are going to use where. Yeah, anybody? Where do I use gridiron incision? Where do I use Rutherford incision? Where do I use skin crease incision? And where do I use midline incision? Yeah, gridiron or Macarthur is used where? Skin crease is used where? Midline is used where? And Rutherford Morrison is used where? Half of you, if you get this shit, your Viva will revolve only around the incisions. It will not really go to the steps because they know you know the steps. Somebody has taught you or you have mugged it up. So they will ask you this more. At least that's what I have seen. In all the students' exams that I have seen them focusing more on this. That's why I'm spending some time on this. Midline for large appendix, midline for pelvic appendix. Okay, I like the way you guys are thinking. I'll give you very simple, very simple way. Very simple. Routinely, what is the meaning of routine? Routinely, you're talking like a surgeon. Answer like a student. What do you mean routinely? At least you have to answer like my student should answer either. What is routine? रूटीन करके कोई टर्मिनोलॉजी नहीं होती है इन मेडिकल साइंस. Where do I use Macarthur or gridiron incision? Yes? Anybody? What she's intending to say is correct, but the terminology is not correct. It has to be more refined than the word routine. So Macarthur is used for uncomplicated appendicitis. Means it's not perforated, there is no abscess, things are okay. Only the appendix is inflamed. I will use uncomplicated. Elective appendectomy, not a good way of saying it. Uncomplicated. Weir's extension is used if the appendix cannot be easily located, like if the appendix is going very retrocecal, बहुत पीछे जा रहा है, retrocecal है पर बहुत ज़्यादा है, या subhepatic, where I need a little more exposure. This is mainly for exposure. When location is ideal, it's not as simple as that, na. Just location is ideal, I come to know during the surgery. Skin crease incision is taken if the person desires cosmesis. So I remember I was seeing someone's exam being taken, and the examiner asked the student, "Okay, which incision will you give if you are operating on Katrina Kaif?" These were his words. Or which incision would you give if you want to go sunbathing? So skin crease incision if you want cosmesis. Midline incision is usually done if it's a perforated appendix. And if the examiner asks you which of these incisions will give you maximum exposure, what is your answer going to be? Maximum exposure. A, B, C, D. 1, 2, 3, 4. Which of these incisions will give you maximum exposure? What will be your answer? Yes. Maximum exposure is seen in gridiron, Rutherford, Lance, or midline. Tira is saying Rutherford, Morrison. Anyone with a different answer? Midline. Always midline. Always midline. Alright, now we'll quickly discuss important parts of open appendectomy. Just the important parts, just the things that you need to know in the exam. So we are going to talk about the main incision, the Macarthur incision. So you cut the skin perpendicular to the spino-umbilical line at McBurney's point. So skin is cut, subacute fascia is cut. Then you will see external oblique muscle, which will be along the direction of fibers. So all you do is you separate the external oblique muscle, separate it, part it in this direction. So external oblique muscle is going to be split or separated. उसके नीचे will be internal oblique muscle, transverse abdominis muscle, which are also going to be split. This is a little difficult. This is the part where your exposure gets compromised because they are not in the direction of your incision. So after I have split the external oblique, उनको मैंने ऐसे साइड में कर दिया ऐसे, नीचे will be my internal oblique, उसके नीचे will be my transverse abdominis, which also I split. So it's a muscle splitting incision. I don't cut it as much as possible. Okay, if I get enough exposure. Then I open the peritoneum. Peritoneum is opened. Once I've opened the peritoneum and I'm looking inside, all the layers are cut, I am looking inside. I first look at the cecum. Okay, I try to identify the cecum. How do I identify cecum? Anybody? I have to identify cecum. That is the first thing I do. कैसे मिलेगा मुझे cecum? Yeah. So first things first, it will be hollow, it will be distended, and it will show the tinea coli. It may or may not be mobile. Usually cecum is fixed. So I identify the cecum, I look at the tinea coli. Where the tinea coli merge, remember your colon has three tinea coli. Where they merge, where they come together, that is where usually I will find the base of appendix. So this is how I will identify the appendix. Where the three tinea coli are going to merge. Where they merge, I will see the base of the appendix, and since it is going to be inflamed, I will try to free the appendix. Okay, means I try to free it, separate it from the cecum if it is stuck. After that, so now I see the cecum, I see the nice appendix like this, bada sa appendix. You know what an inflamed appendix is now? Almost the size of your little finger. Normal appendix will be thin, it will be just a part of your little finger. So your inflamed appendix will be like this, अच्छा बड़ा लंबा चौड़ा फुगा हुआ, and it will have its mesoappendix like this. So what I do is I try to deliver the appendix outside. Deliver appendix outside the abdomen. Okay, means try to bring it out from the abdominal wound. जो मैंने incision लिया है उससे मैं उसको बाहर निकालने try करता हूँ. This is the important part. Now once the appendix is delivered, I devascularize it. So whatever blood vessels are going into the appendix, they are ligated. So devascularize the appendix. Okay, appendix has a mesentery. It's called mesoappendix, where all the blood vessels are running. I identify the vessels are ligate and I cut. So then what I am left with is a bare appendix with nothing else. What do I do after this? Whatever I am writing in red are the important points. What after I devascularize the appendix? What do I do then? Yes. अब क्या करूँ मैं? After I have devascularized it, transfix the base. Anything before that? Before I transfix? Anything I do before that? Before transfixation? Yeah. So now all I have is the cecum and the appendix like this. You are saying transfix the base. Anything before that? Anybody? Before I transfix the base of the appendix? Crush the base. Very good. What do I crush the base with? Exam question. Crush the base of appendix with what? With? We saw this instrument yesterday. So I take that instrument and I apply it at the base of the appendix and I crush it. Lockers. What's a locker? Cocker. Hemostat. Okay. With a straight hemostat. Not cocker, straight hemostat. No, not sponge holding. Sponge holding is very big. I need a straight hemostat. So in your exam, if they give you a hemostat, it will either be straight or it will be curved. Then typically they ask you, where do I use straight hemostat? Crush the base of appendix. Classical use. I don't use a curved one because it has to be flush. Right? It has to be at the level of the base. So I use a straight hemostat and I crush the base of the appendix like this. Okay, I crush the base of the appendix. So now the base is crushed. After the base is crushed, wherever I applied it, so let's say I crushed it over here at the base, then I ligate it. No, पहले crush करूँगा फिर ligate करूँगा. Crushing is not the end of the story. Then I put a suture at the crushed area. So I ligate it. Flush means at the level of the base where it is joining the cecum. Then I pass a ligature where I have crushed it and then I cut above. तो उसके ऊपर मैं काट दूंगा and the appendix will be removed. Okay? Any question anybody has at this stage? That's how I have removed the whole appendix, almost the whole. Very little stump will be left behind. Whatever part was crushed, that is a little bit that is left behind, where I have ligated it. And then I cut above it. So a little appendicular stump will be left behind, little bit, few 2-3 millimeters. What is preferred, ligation or transfixation? It doesn't make a difference. It's a personal choice. You can do either. No, special situations we are coming to. Don't worry about it. वो लिखा है मैंने इधर. Special situations. Don't worry, Sonali. All special situations are here, but I don't want to jump there yet. Okay. So ये था मेरा सीकम. ऐसे जा रहा था अपेंडिक्स. बेस को मैंने क्रश किया, उधर लाइगेचर किया और बाकी का अपेंडिक्स निकाल दिया. End of the story. Then close the incision with sutures and appendicectomy is performed. Any problem at any of these stages? Please have it clear right away. You don't have any question? Nobody has a question? Are you sure? Acha. Okay, then I will ask you a question. Why am I crushing the base? Why don't I just ligate it and cut it like I did cholecystectomy? Cholecystectomy में मैंने cystic duct को थोड़ी crush किया. उसको तो मैंने सीधा ligate किया. Otherwise, forget the transfixation part. We don't need that. For us, ligation is what we have done. Forget the transfixation. Don't worry about it. Why am I crushing the base with a hemostat and then ligating it? जो मैंने cystic duct में नहीं किया. Cystic duct तो मैंने सीधा ligate किया. यहाँ क्या खास बात है भाई appendix में? That I am crushing it. Yeah, that's my question. Why to crush the base? जरूरी है क्या? Recurrence. अरे अपेंडिक्स निकाल दिया मैंने, रिकर कहाँ से होगा? नया अपेंडिक्स थोड़ी आएगा उधर. Nural, don't tell like that. Come on. Nural, you're attending my class every day. to prevent stump inflammation. वो तो stump के size के ऊपर depend करता है. If the stump is small, then you won't get stump inflammation. Anything better answer? Why am I crushing the base? This is the stump where I have crushed it. If I just ligate it, is it a problem? Do I have to crush it? Crushing between hemostats, just like we do it in tonsils. Hemostasis. Ligature will also do hemostasis, na? The ligature will also do hemostasis to reduce swelling. But base is not inflamed. To prevent infection going into the cecum, ligature will prevent the infection going into the cecum. That is the job of the ligature. एक बार मैंने यहाँ पे एक टाई कर दिया तो कुछ थोड़ी नीचे जाएगा. Yeah, anybody? What is the dreaded complication of this procedure? Think of it like that. What is the dreaded complication, acute complication of this procedure, which can really make the life of the patient miserable? So I have tied the ligature at the base. Something goes wrong. What will happen? If you just ligate, the ligature may slip. Very good. Very good. So crushing is going to prevent the ligature from slipping. Is that what you are saying? Crushing will prevent the ligature from slipping. Peritonitis. Okay. The dreaded complication is, yes, the ligature will slip and the feces starts leaking. He'll get fecal peritonitis, which is a disaster. Ligature cannot slip. When I crush the base, what happens? Two things happen. One answer somebody gave. When I'm crushing the base, the fluid gets reduced. The edema fluid gets drained. So the ligature sits better. The ligature won't slip. Okay, because then the knot will be perfectly tied. The second thing is, when I crush the base, it will promote fibrosis. The fibrosis will be better. So there are two reasons why I crush the base. One, so that it fits properly, the fluid gets drained, and second is it will promote fibrosis, so the stump will heal very fast. So the chances of fecal fistula again are very less. But let me tell you, crushing the base is not mandatory. It's not mandatory. This is more hypothetical. That yes, maybe the ligature slippage reduces and the fibrosis increases. It's hypothetical. It's not proven. Okay, it's not proven. Which is why there are special situations. What do I do if the base is also inflamed? So my appendix, even the base of the appendix is inflamed. The inflammation has reached till the base of the appendix. What do I do here? Somebody was asking. ये situation में क्या करूँगा मैं? If the base is also inflamed. Normally inflammation is in the tip and the body. Base में normally नहीं होता. यहाँ पर base में भी inflammation है. Then what do I do? Yes, any different thing I will do if the base is inflamed? Because somebody asked this question. Don't crush. Very good. Don't crush the base. What will happen if I crush the base? What will happen if I crush the base? If I put a hemostat on the inflamed base, what will happen? And if I don't crush, then what? So if I crush an inflamed or an edematous base, it will avulse. तो वो निकल जाएगा. Appendisectomy तुम्हारा ऐसे ही हो जाएगा. The appendix will just get disconnected. So don't crush, straight away ligate. सीधा ligature लगा दो base पे. Don't crush it. What do I do if the base is gangrenous? Base is gangrene. Then what do I do? This is a tricky situation, because if the base is gangrenous, I cannot put ligature on gangrenous appendix. Okay, because वो तो ligature 100% slough off हो जाएगा. If the base is also gangrenous. So what do I do in that case? Hemicolectomy. Anything simpler I can do than hemicolectomy? What does Bailey say? If the base is gangrenous, what should I do? Yeah, right, hemicolectomy. Purse string suture. No, not purse string suture. Purse string is to bury the appendix. Bury the stump. वो जो आजकल करते नहीं है. Resection and anastomosis means resection of the cecum and ileoascending anastomosis. ऐसे बेली में क्या दिया है? Remove appendix and cecum. वही तो मैं बोल रहा हूँ. And then ileoascending anastomosis. Is there anything simpler? So if the base is gangrenous, what I do is I remove the entire appendix. So what will happen is there will be a hole in the cecum where the appendix was attached. So remove the entire appendix, and by removing the entire appendix, what has been created is called a cecotomy. Because वो appendix पूरा निकाल दिया मैंने, पूरा gangrenous था, पूरा appendix निकाल दिया. So there is a hole on the cecum that is called cecotomy, which I suture. I just put suture. I treat it like a perforation and I suture close it. End of the story. Hemicolectomy is usually not required. That is the other option. Yes, you can do right hemicolectomy, but what Bailey says is first attempt this cecotomy and suture the cecotomy. Means remove the entire appendix. So this is the cecum. I'll give you side on view. This was the appendix. Base was also inflamed. Remove the entire appendix. You will be left with a hole at the roof of the cecum. Just suture it. End of the story. Okay, stoma need not be done. If you feel, you can do it, otherwise no. What if there is a tumor? Inflamed base may, if it's inflamed, the inflammation will go. Now you don't have to do this. Inflammation will go, but gangrene will not go. Inflammation is reversible, gangrene is not reversible. So in inflame you can leave the stump. What do you do if you find a mass in the appendix? So patient was diagnosed with appendicitis. Okay, but there is a big mass at the tip. What do I do? I am trying to give you all possible scenarios. There are more scenarios if you read Bailey and Love. Tumor में तो पक्का hemicolectomy. वाह द्वैत वाह, पक्का hemicolectomy. तुम पक्का surgeon. Surgical answer. Resect as much as possible, है ना? Yeah, anybody? If I see a tumor at the appendix, frozen नहीं, tumor means I assume it is malignant. No frozen भी नहीं चाहिए मेरे को. Either it will be adenocarcinoma or it will be carcinoid. It's not going to be benign. Appendix में benign tumors नहीं होते. Assume malignant. क्या करूँगा? Yeah, anybody? There are two options. This is what I was telling you earlier. If the tumor is less than 2 centimeters and it's at the tip, then just do appendicectomy. If the tumor is more than 2 centimeters or it is at the base, then do right hemicolectomy. Okay, so when I gave you indications of appendicectomy, this is what I was trying to ask you. Nobody paid attention there. I told you I'll give you the size. Appendicitis or tumor less than 2 centimeters. And at the tip. More than 2 centimeters or near the base of the appendix, you will do hemicolectomy. Because that means you have to do lymphadenectomy also. Are we very clear on this? And the last part, you find a normal appendix. Patient was diagnosed with appendicitis, right iliac fossa pain. Ultrasound showed maybe it's a distended appendix more than 6 millimeters. I do the Macarthur incision, I find a normal looking appendix. You know, like the little finger, small part of your little finger, thin appendix, not inflamed, no adhesions, no inflammation. What do I do? Remove it anyway to prevent confusion later. Again, Ria is also speaking like a surgeon. I think Ria, Advait, Mayuresh are all surgical acumen people. Hmm? Remove it anyway. Wow. So if you find a normal appendix, the first answer you will give is trace the ileum. Thank you, Sonali. Trace the ileum. How much do I trace the ileum to look for Meckel's? To look for Meckel's, how much do I trace the ileum? How much? Full ileum I can trace through my Macarthur incision. Today I really enjoyed taking the class. Normally I feel like okay, 5 minutes more, 5 minutes more. Today I don't want to stop. Yeah, absolutely right. 2 feet. Because Meckel's, remember, follows the rule of tools. So it is usually up to 2 feet proximal to ileum, terminal ileum. Usually up to 2 feet. Okay. So up to 2 feet I should trace. Anything else I should look for which can mimic appendicitis. Anything else I should look for. Anything else I should trace or look for before labeling him as normal appendix. And of course, if I label him as normal appendix, it's a dangerous thing. Ectopic pregnancy in females. Uh, Ectopic pregnancy is a more dangerous thing. You could have simply said look for tubo ovarian pathologies. Okay, look for tubo ovarian pathologies. बस that's it. अगर ये दोनों में से कोई चीज मिल गई, treat that. If both these things are negative or normal, then only you will do appendectomy. So yes, I will not say Ria was wrong. You will do an appendectomy even if it's a normal looking appendix. But first rule these two things out. ये दोनों में से अगर कोई चीज positive है, then obviously you will treat that. If they are negative, then you will do appendectomy. Fine. Are we good? Then last part is the complications of appendectomy. So again, I need you to know only one early complication, one late complication. Early is leak. That will give you fecal peritonitis. What is the most important late complication of appendectomy? Most important, most common late complication of appendectomy. Yeah, late complication of appendectomy. If positive, then not remove. Then of course don't remove. If there is Meckel's diverticulitis, don't remove the appendix. Then treat the Meckel's diverticulitis. Infection is not a late complication. Infection is an early complication. Adhesive obstruction. Excellent, Mayuresh. Adhesive intestinal obstruction. This is the most important and most common late complication of appendectomy. I will not discuss these. I will only discuss this one. Yeah, anybody can identify this imaging? What is this imaging? And what is it showing? First tell me what is the name of this imaging. Then tell me what is it showing. CCT of what? Mayuresh? CCT, CT of what? His brain? After so many months. Okay, yeah, it is CCT abdomen. Please understand this is not X-ray of X-ray. It looks like an X-ray, but it's not an X-ray. Okay, in an X-ray you can never see the liver like this. It's just a view of a CT scan. It's a coronal view. This is the liver. Probably this is the stomach, which has some contrast. Person was made to drink some contrast. Okay, so this is a CCT. You can see the liver, you can see the stomach, you can see the small bowel over here. This is probably the urinary bladder, probably. All this is bowel loops. This is mesentery. Is it a normal one? CCT abdomen, what is it showing? Does the small bowel look normal to you? Yeah, anybody? There are three abnormal findings in this CCT abdomen. Three. And the fact that I have put it means it is MBBS level if someone is helping you. Like I'm a helpful person, I will help you crack the code. Enhanced circular mass seen above the bladder. Excellent, Mayuresh. This is the most obvious pathology. Don't call it enhanced. Okay, it's not enhanced. But yes, it's a circular mass of some sort. You should call it hyperdense. You know, CT, we look for density. MRI, we look for intensity. X-ray, we look for opacity. And ultrasound, we look for echogenicity. So this is a hyperdense, concentric pathology, somewhere in the right iliac fossa. Is the bowel looking normal? Do you feel the small bowel is normal? Air in intestine में तो air होनी चाहिए ना भाई. Is this normal? This air, the small bowel. Anything? Do you feel the small bowel? Should you see air in the small bowel? Okay, I'm going to help you. The air that you see here and here. Should you see air in small bowel? Maybe this also. Dilated. Okay, so there is some opacity here. There is a dilated small bowel. Okay, it's dilated. It has air. I won't say air fluid levels, but it is dilated. So two pathologies you have. You have an opacity here. You see air. It's not pneumoperitoneum. All the air is inside the bowel. It's not free air. The air is not free. If the air was free, then this should not be there. Definitely this has something to do with the CT. I'll give you a clue. What is all this inside the liver? What is all this? See, I am a very helpful person. Your examiner will also be helpful. What is all this? Do you expect this inside the liver? Yeah. It's one of a kind CT. I tried to find X-ray also of this. What is this third thing? Pneumobilia. Excellent. Pneumobilia. Air in the biliary tree. Please understand there should be no air in the biliary tree. There should be no air in the peritoneum, no air in the kidney, no air in the urinary bladder. In any of these places, if you see air, it is pathological. All this black thing that you see is air in the biliary tree. These three together is regular striate. This is regular striate. This is, as Advait correctly said, gallstone ileus. This is gallstone ileus. What I'm trying to say is, if you're given images like these or CT films like these, don't be taken aback. Okay, don't be taken aback. NEET PG में तो ये सभी पूछते हैं. They are not going to give you X-ray of intestinal obstruction ऐसे वाले. Okay, ये सब नहीं पूछेंगे. NEET PG में तो ऐसी चीज पूछेंगे, but they will give you clues. And in your exam also, the examiner will help you. If you can't identify the X-ray, he will tell you, okay, what do you see? What do you think this is? This is the opacity because of gallstone, which has gone into the small bowel, caused the small bowel obstruction and the air in the biliary tree. So there is a cholecystoenteric fistula from which the stone went and caused intestinal obstruction. Why is it over here? Normally the stone obstructs in terminal ileum. See, everything falls in place if you know what you have to look for. If you have never heard of gallstone ileus, then examiner will say, okay, forget it. You tell me this X-ray, which you will tell with your eyes closed. Sir, this is dilated small bowel loops, probably jejunal obstruction, concertina pattern. ये तो तुम नींद में भी बोल दोगे concertina pattern, right? So don't be taken aback. Be confident, and the examiner is there to help you. All right. So take his help. Be confident, and try to find your way around it. There will be another class tomorrow at 6:30 p.m. That will be an image-based class of surgery and orthopedics both. Okay, it will be surgery and orthopedics both. So there will be some orthopedic X-rays. I will ask some clinical scenarios in orthopedics and surgical scenarios, obstruction, clinical features. So it will be interesting clinical plus imaging pattern class. Do join me for that tomorrow same time again on YouTube. And please follow me on my Telegram channel. Those of you who are not on my Telegram channel, please follow me on Telegram where you will get regular updates. And of course, if you want to learn on the Plus platform, use my referral code 10surgery. That will get you a discount. Okay, so thank you for joining me, guys. Have a good weekend. Study well and see you tomorrow again.